Welcome to the Deep Dive. Today, we're plunging into the incredible inner workings of your body, specifically the cardiovascular and lymphatic systems. These aren't just, mere pipelines. They're the bustling highways and hidden battlegrounds where your immune system confronts threats head-on.
That's right. And we're drawing directly from Microbiology, an introduction, the 13th edition, to really uncover the most critical insights about the microbial diseases that can hijack these vital internal networks.
Okay.
Our goal is, well, to give you a clear shortcut to understanding everything from invisible bacteria to complex parasites, their surprising strategies, and the real-world impact they have on human health.
So what's the big picture here for you, the listener? Well, you're about to gain a really well-rounded understanding of conditions like sepsis, the historical shadow of the Black Death, the widespread challenges of Lyme disease, and even why a seemingly minor cat scratch can become far more serious than you'd expect. Prepare for some truly illuminating moments because we are diving deep.
Let's do it.
Okay, let's begin by mapping out our internal transportation system. On one side, you have the cardiovascular system. That's your heart, the vast web of blood vessels, and the blood itself, constantly circulating life-sustaining nutrients and oxygen while, whisking away waste. It's the primary delivery service, really.
And intricately connected to this, almost like a parallel network, is the lymphatic system. It's less visible, maybe, but equally crucial.
Right.
This includes lymph vessels, lymph nodes, and critical organs like your tonsils, appendix, spleen, and thymus. You can think of the lymph system as your body's dedicated drainage and surveillance network, always filtering, always checking for trouble.
It's quite elegant, actually, the way it works. Blood plasma, the liquid part of your blood, it continually filters out of your capillaries into the spaces between your tissue cells.
Right, into the interstitium.
Exactly, becoming what we call interstitial fluid. And here's a crucial step. This fluid is then collected by these highly permeable lymph capillaries, transforming into lymph. This lymph eventually makes its way back to your bloodstream, but not before passing through a series of vigilant checkpoints to your lymph nodes.
Yeah.
That's where immune cells are waiting.
It's really remarkable how these sophisticated systems, despite their built-in defenses, can sometimes become the very pathways for infection.
Yeah, it seems counterintuitive.
Well, pathogens, whether they get in from an insect bite, maybe a needle or a wound, they can find their way directly into the circulation. And while your blood and limbs are packed with defensive cells, phagocytes, B cells, making antibodies, T cells.
All the key players.
Right, all the key players. But sometimes these defenses are simply overwhelmed. That leads to, well, a rapid microbial takeover. Consider the dengue virus, for example, transmitted by mosquitoes. It has this cunning strategy. It specifically targets and multiplies within your immune system's own macrophages.
Wow, using the defenders against themselves.
Pretty much. And here's something that really upends what we long believed. For centuries, the conventional wisdom was that healthy blood was sterile, completely sterile.
Right, that sounds familiar.
Yet recent studies using advanced genetic tools looking for bacterial 16S DNA, think of it like a universal genetic fingerprint for bacteria, now suggest that healthy human blood actually has its own microbiome.
Seriously?
In the blood.
Yes. Now, most of this bacterial DNA isn't just floating freely in the plasma. It seems to be found nestled within white cells and platelets, mostly.
Okay.
This hints that bacteria from, say, our mouth or intestines might regularly and perhaps harmlessly cross mucous membranes into the bloodstream. A totally different picture.
So our circulatory systems are indeed busy highways, and unfortunately, sometimes unwanted passengers get on board, which brings us to one of the most dangerous bacterial conditions we need to understand. Sepsis.
So, sepsis. It's crucial to understand that sepsis isn't just an infection. It's your body's extreme, often life-threatening response to an infection.
The response itself is the problem. Largely, yes. It occurs when pathogenic microorganisms or their toxins are present and persist in the blood, triggering this systemic inflammatory response. Sometimes you can even see signs like inflamed lymph vessels appearing as telltale red streaks under the skin. That specific sign is called lymphangitis.
That's a critical distinction then. Many people use sepsis and septicemia almost interchangeably. Can you clarify the difference there?
Absolutely. It's a common point of confusion. Septicemia, strictly speaking, refers to the presence and active proliferation of pathogens in the blood. You can find them multiplying there.
Okay.
Sepsis, on the other hand, is the broader, often far more serious inflammatory cascade that occurs throughout the body.
Right.
And this systemic response can happen even if microbes aren't directly detected in the bloodstream at that moment. It's the body's overreaction that really causes the widespread damage.
And the progression sounds incredibly fast.
It can be terrifyingly swift. From the initial sepsis, often marked by fever and chills, it can rapidly escalate to severe sepsis that involves shock and organ dysfunction.
Yep.
The most critical stage is septic shock, where blood pressure drops to dangerously low levels and can no longer be controlled by fluids or medication.
That sounds grim.
It is incredibly serious.
Yeah.
In the U.S. alone, it affects over 1 million people annually, with a fatality rate somewhere between 28 and 50%. Huge numbers.
So what are the main culprits behind this devastating condition? What kind of bacteria are we talking about?
Well, historically, gram-negative bacteria were particularly notorious for causing septic shock.
Gram-negative. Okay.
The critical insight here lies in their cell walls. They contain these powerful toxins called endotoxins, specifically lipopolysaccharides, or LPS.
Right.
When these bacteria die and their cells break apart, or lyse, these endotoxins are released in large amounts. That sudden release causes a dramatic and dangerous drop in blood pressure.
Ah, okay.
We see this with common bacteria like Klebsiella, E. coli, Pseudomonas aeruginosa, and even some emerging threats like Elizabeth Kingia species. Surprisingly, an invasive, multi-drug-resistant fungus, Candida auris, is also increasingly recognized as a cause of sepsis.
So treating gram-negative sepsis sounds like a double-edged sword if the antibiotics themselves cause the release of more toxins.
Precisely. That's a real clinical challenge. Antibiotics are absolutely essential to kill the bacteria, but their initial action can sometimes worsen the condition temporarily by causing this mass bacterial lysis and a sudden flood of endotoxins.
Wow.
Unfortunately, efforts over the years to develop treatments that neutralize these endotoxins or block the inflammation-causing cytokines haven't really panned out successfully yet. It's tough.
But it's not just gram-negative bacteria anymore, is it?
No, absolutely not. In fact, gram-positive bacteria are now the most common cause of sepsis,
Really? Like what?
particularly Staphylococcus and Streptococcus.
Yeah.
These produce potent exotoxins that are actively released by the living bacterial cells.
Okay, exotoxins, different mechanism.
Different mechanism, same dangerous outcome. And a significant risk factor, maybe surprisingly, comes from healthcare settings. Hospital-acquired infections, especially in patients undergoing procedures like dialysis, are a major source.
That makes me wonder about some of the bacteria we might encounter in a hospital. Why are enterococci, which I thought were considered relatively harmless gut bacteria, now leading causes of healthcare-associated infections, like Enterococcus faecium and Enterococcus faecalis?
That's a great question, and it really highlights a critical challenge in modern medicine: antibiotic resistance. These Enterococci, they have a natural intrinsic resistance to penicillin.
Okay.
And on top of that, they've rapidly acquired resistance to many other antibiotics through genetic exchange. We're now seeing alarming rates, like nearly 90% of some strains being vancomycin resistant, VRE. That makes them incredibly difficult to treat.
Wow, 90%.
Yeah. And we also have to mention group B streptococci like S. acalactia. These are the most common cause of life-threatening neonatal sepsis in newborns. Very serious.
Let's shift our focus a bit to a historically profound disease. Puerperal sepsis, often tragically known as childbirth fever?
Yes. This was a devastating infection of the uterus that could occur after childbirth or abortion. It frequently progressed to peritonitis infection of the abdominal lining and then full-blown sepsis.
It sounds terrifying for mothers back then.
Imagine the horror.
Yeah.
Between 1861 and 1864, a major Paris hospital reported a staggering 12% mortality rate among birthing mothers due to these infections. 12%.
Unbelievable.
The breakthrough came from visionaries like Oliver Wendell Holmes in the U.S. and Ignaz Semmelweis in Vienna. Decades earlier, they observed and meticulously demonstrated that the disease was being transmitted by the unwashed hands and contaminated instruments of doctors and medical students moving between autopsy rooms and maternity wards.
So it was being spread by the caregivers themselves.
Exactly. Their tireless advocacy for simple hand disinfection, which was initially met with resistance, combined with the later advent of antibiotics like penicillin and modern hospital hygiene practices, has thankfully transformed this from a near-death sentence into a rare complication today. It's a powerful, powerful lesson in public health history.
Absolutely. Okay, so from these systemic infections, microbes can sometimes find a specific foothold directly in the heart itself. Let's talk about endocarditis. What is that exactly?
Endocarditis is an inflammation of the endocardium. That's the inner lining of your heart chambers. and, crucially, your heart valves.
Okay, the inner lining and valves.
And there's a really important distinction here between subacute and acute bacterial endocarditis. They behave very differently.
How so?
Subacute endocarditis develops slowly, often over weeks or months. It's frequently caused by alpha-hemolytic streptococci, which are actually common bacteria found in the mouth.
From the mouth. How do they get to the heart?
Well, it typically originates from a localized infection, maybe something as seemingly minor as a tooth extraction or even vigorous toothbrushing that causes Transiobacteremia bacteria in the blood.
Ah.
These bacteria can then find their way to the heart and lodge, particularly on pre-existing heart valve abnormalities, maybe valves damaged by a previous condition. Once there, they become entrapped in tiny blood clots, forming vegetations. And this cleverly shields them from your immune system's attacks.
Sneaky. And the danger, then?
If it's left untreated, this slow burn infection can severely impair heart valve function as the vegetations grow, and it can eventually prove fatal within months.
Okay, so that's subacute. What about acute endocarditis?
Acute bacterial endocarditis is a whole different beast. It's often caused by the much more aggressive Staphylococcus aureus.
Staph aureus. Very well.
This form comes on suddenly and rapidly destroys heart valves, even previously healthy ones. Without immediate aggressive treatment, it's frequently fatal within just days or weeks. The speed and intensity are terrifyingly different.
Wow. Now, thinking more broadly, we sometimes hear about strep infections leading to heart issues, but maybe not as a direct infection. Can you explain that connection?
You're likely referring to rheumatic fever. That's a serious autoimmune complication that can follow certain strep throat infections, specifically those caused by Streptococcus pyogenes or group A strep.
Autoimmune, meaning the body attacks itself.
Precisely. It's not the bacteria directly infecting the heart tissue in this case. Rather, it's an immune reaction that goes awry.
So how does this affect someone, especially kids? I hear it's more common in children.
It primarily affects children aged about 4 to 18, and it typically follows an untreated or inadequately treated strep throat infection by a couple of weeks.
Okay.
Initial symptoms can include arthritis, joint pain, and fever. But the real danger is that in about half of the cases, it leads to inflammation of the heart carditis.
And what causes that inflammation?
It's thought to be due to a misdirected immune response. The body produces antibodies against a protein on the surface of the strep bacteria called the M protein. Unfortunately, some proteins in the human heart tissue look very similar to this M protein.
Molecular mimicry.
Exactly, molecular mimicry. The antibodies mistakenly attack the heart valves and muscle, causing inflammation and potentially permanent damage.
That's awful. And isn't there a strange neurological symptom, too?
Yes. There's a truly bizarre neurological complication called Sydenham's chorea, historically known as St. Vitus's dance. It causes involuntary jerky movements.
Wow.
The key takeaway here, really, for prevention is the importance of prompt diagnosis and complete treatment of strep throat infections with antibiotics, usually penicillin. That prevents the initial immune sensitization.
Makes sense. Okay, now let's turn our attention to some fascinating diseases that make the leap from animals to humans. These are called zoonoses. First up, tularemia, often nicknamed rabbit fever.
Right, tularemia. It's caused by a bacterium called Francisella tularensis. It's quite hardy.
And how do people usually get it? Handling rabbits.
That's the most common way, yes.
Yeah.
Direct skin contact with infected rabbits or rodents, perhaps during hunting, skinning, or handling carcasses. It typically causes an ulcer at the site where the bacteria entered the skin,
Okay.
followed by swelling and tenderness of nearby lymph nodes, which can fill with pus. But it's not just direct contact. It's also transmitted by the bites of infected ticks and deer flies, which is why it's sometimes called deer fly fever.
Oh, ticks and flies, too. Okay.
And even inhaling dust contaminated with waste from infected animals can cause a serious form, an acute pneumonia, which carries a pretty high mortality rate.
That sounds dangerous. Any other sources?
And here's a detail that often surprises people. Domestic cats can also become infected and transmitted to humans, usually through a scratch or bite. So careful handling of any sick or deceased wild or domestic animals is really critical.
Good to know. Okay, another globally significant zoonosis is brucellosis, sometimes called undulant fever. You mentioned it's the world's most common bacterial zoonosis.
It is, yeah. Over 500,000 new human cases each year worldwide. It's caused by bacteria of the genus Brucella. These are small, gram-negative coccobacilli.
And how do they spread to humans?
They typically enter through minute breaks in the skin or through mucous membranes, often from contact with infected animals or their products.
Like what kind of products?
Unpasteurized milk or cheese is a common source globally. Once inside the body, Brucella have this clever strategy. They get taken up by macrophages, which are immune cells supposed to destroy invaders.
Right.
But Brucella actually reproduce inside the macrophages, hiding from the broader immune defenses. This allows them to evade destruction and often leads to a persistent chronic infection that can last for years.
Wow. Which animals carry it most often?
Different Brucella species prefer different hosts. The most serious species for humans, Brucella melitensis, is commonly found in goats and sheep. In the U.S., it's frequently associated with imported unpasteurized dairy products, like some soft cheeses from Mexico, for instance.
And why undulant fever?
It gets that name from its characteristic fever pattern. The fever often rises and falls in waves, sometimes spiking in the evenings or at dusk, giving it this undulating pattern. It can also cause malaise, sweats, aches, a really debilitating chronic illness.
Okay. Speaking of historically devastating diseases, let's talk about anthrax, caused by Bacillus anthracis.
Anthrax. Yes, Bacillus anthracis is a gram-positive, rod-shaped bacterium famous for forming incredibly resilient endospores.
Endospores. Those are the tough, dormant forms.
Exactly. They can survive in soil for decades, possibly up to 60 years or even longer under the right conditions. Grazing animals like cattle and sheep ingest these spores while feeding, and the spores then germinate inside the animal, leading to often fatal sepsis.
And how does it affect humans?
Humans typically contract anthrax in one of three main forms, depending on how they're exposed to the spores.
Okay, what are they?
The most common natural form is cutaneous anthrax. This happens when endospores enter the skin through a minor cut or abrasion, maybe from handling infected animal hides or wool. It results in a characteristic lesion that starts as a papule, then vesicles, and finally forms a painless black scab called an eschar.
Cutaneous. Skin. What else?
Then there's gastrointestinal anthrax, which is much rarer but more severe. It comes from consuming undercooked meat from an infected animal, causes nausea, vomiting, abdominal pain, bloody diarrhea.
Sounds awful.
But the most dangerous form by far is inhalational anthrax, sometimes called wool sorter's disease. This occurs when someone inhales a large number of airborne endospores.
Inhaling them.
Yes. The spores travel to the lungs, are taken up by macrophages, and then travel to the lymph nodes in the chest, where they germinate and release potent toxins. It leads to symptoms like fever, cough, chest pain, and rapidly progresses to septic shock and respiratory failure. If left untreated, inhalational anthrax has a near 100% mortality rate.
That's terrifying. And the bioterrorism link.
Exactly. Because the spores can be weaponized and dispersed as an aerosol, causing inhalational anthrax, it's considered a major bioterrorism threat. That's why rapid diagnostic tests for anthrax are so critical in potential exposure scenarios.
Makes sense. Okay, let's pivot to something different but also quite serious. Gangrene. This is when tissue dies, right?
Yes, gangrene is essentially tissue death or necrosis caused by a loss of blood supply to the area. This condition is called ischemia.
And what does that loss of blood supply do?
Well, when the blood supply is cut off, the tissue doesn't get oxygen. It becomes anaerobic. This creates the perfect environment for certain types of bacteria to thrive, particularly anaerobic bacteria like Clostridium perfringens.
Clostridium perfringens, where does that come from?
It's actually quite common, found in soil, and also normally present in the human intestinal tract.
Okay, so what happens when it gets into oxygen-deprived tissue?
In that anaerobic environment, Clostridium perfringens ferments carbohydrates present in the muscle tissue. This fermentation produces gases like hydrogen and carbon dioxide, which build up and cause the tissue to swell conspicuously. That's why it's often called gas gangrene.
Gas gangrene, right.
But it's not just the gas. The bacteria also release powerful exotoxins that destroy surrounding cells, including muscle cells and red blood cells, leading to further tissue necrosis and allowing the infection to spread rapidly.
So how is it treated? It sounds like it could spread very fast.
Treatment has to be prompt and aggressive. Often it involves surgical debridement, the removal of all the dead infected tissue. In severe cases, amputation of the affected limb might be necessary to save the patient's life.
Amputation.
Drastic.
It can be. However, another effective treatment, especially if caught early, is hyperbaric oxygen therapy.
Hyperbaric oxygen, how does that work?
The patient is placed in a chamber with high pressure, 100% oxygen. This floods the tissues with oxygen, creating an environment where these obligate anaerobic Clostridium bacteria simply cannot grow and produce their toxins. It can be very effective in halting the progression of the infection.
Interesting. Okay, finally in this section, let's consider systemic diseases spread through animal bites and scratches. You mentioned earlier that cat bites, though maybe less common than dog bites, actually have a higher infection rate. Why is that?
It largely comes down to the nature of the bite. Cat teeth are sharper and more slender than dog teeth. They tend to create deep puncture wounds.
Ah, deeper inoculation. Exactly. These deep punctures can deliver bacteria further into the tissues, closer to joints or bones, and they're also harder to clean out properly. Dog bites, while they can crush tissue more, are often more tearing or lacerating, maybe easier to irrigate.
Makes sense. And what kind of bacteria are we worried about from bites?
A key one carried by many domestic animals, dogs and cats included in their mouths, is Pastorella multocida. It's a gram-negative rod.
Pastorella multocida.
A bite can introduce this bacterium, leading to a rapidly developing local infection with redness, swelling, and pain within hours. But it can also sometimes spread, causing more serious problems like cellulitis, bone infections, pneumonia if inhaled, or even life-threatening sepsis, especially
Particularly cat scratches.
Ah, yes. Beyond Pastorella, a surprisingly common condition specifically linked to cat scratches is, aptly named, cat scratch disease.
Right. What causes that?
It's caused by a bacterium called Bartonella henselae. Cats, especially kittens, often carry this bacterium in their red blood cells without showing any symptoms themselves. They usually get it from fleas.
From fleas?
Yes, fleas ingest the bacteria when feeding on an infected cat. The bacteria multiply in the flea's digestive tract and then are excreted in the flea feces, or flea dirt.
Okay.
When a cat scratches itself, it can get this contaminated flea dirt on its claws. Then, if it scratches a person, it can transmit Bartonella henselae into the scratch wound.
So it's really flea dirt on the claws?
Often, yes. The disease in humans typically presents with a small bump or blister at the scratch site, followed by swollen, tender lymph nodes nearby, usually appearing a few weeks later. Usually it's self-limiting in healthy people, but can be more severe in those with weakened immune systems.
Interesting transmission route. And what about rats? Rat bites?
Yes, rat bites can also lead to specific infections, collectively known as rat bite fever. There are actually two distinct forms caused by different bacteria.
Two forms.
One is streptobacillary rat bite fever, caused by Streptobacillus moniliformis. The other is spirular fever, or Sudoku, caused by Spirillum minus. Both typically cause fever, chills, rash, and joint pain after a rat bite. Fortunately, both forms usually respond well to treatment with penicillin.
Good to know. Okay, let's move on now to diseases where insects or ticks act as crucial intermediaries or vectors. And few diseases have impacted human history more dramatically than plague, the infamous Black Death.
Absolutely. The plague, the causative agent is Yersinia pestis, a gram-negative rod-shaped bacterium.
And it's primarily a disease of rats, right? How does it get to humans?
Normally, yes, it circulates among rodent populations, particularly rats. It's transmitted from one rat to another by the bite of an infected rat flea. The species Xenopsilochiopus is the classic vector.
Okay, the flea bites an infected rat.
Right, ingests the bacteria. Now, here's what's really insidious about how Yersinia pestis interacts with the flea. The bacteria multiply rapidly inside the flea's digestive tract, specifically in the proventriculus, which is sort of like a valve before the stomach. They form a sticky biofilm, a mass of bacteria, that physically blocks the flea's gut.
Blocks it.
Yes, blocks it. This means the flea can't properly ingest a blood meal, so it becomes incredibly hungry and tries to feed more frequently and aggressively. But because its gut is blocked, when it tries to suck blood, it just regurgitates the blood it just took in, along with thousands of Yersinia pestis bacteria back into the bite wound of its host.
Wow, that's a remarkably effective, if horrifying, transmission mechanism.
It really is. And when a flea's preferred rat host dies, maybe from the plague itself, the now starving flea will jump to find a new blood meal. Tragically, that new host can be a human.
So how does this manifest in humans? We hear about bubonic plague.
Right, that's the most common form resulting from a flea bite. The bacteria travel from the bite site to the nearest lymph node, usually in the groin, armpit, or neck. They multiply rapidly there, causing the lymph node to become incredibly swollen, hard, and painful. This characteristic swollen lymph node is called a bubo, hence bubonic plague.
Okay, is that the only form?
No. If the bacteria enter the bloodstream, it causes septicemic plague, which is very dangerous. And if the infection reaches the lungs, it leads to pneumonic plague.
Pneumonic plague sounds bad.
It's the most dangerous form.
Yeah.
Nearly 100% fatal if not treated rapidly with antibiotics. And crucially, pneumonic plague can be spread directly from person to person through respiratory droplets produced by coughing.
Person to person. That's how it caused such massive epidemics then.
Exactly. That potential for direct human-to-human transmission is what fueled the devastating pandemics like the Black Death in the 14th century, which killed perhaps a third of Europe's population.
Unimaginable. Does it still exist today?
It does, yes. While large epidemics are thankfully rare due to antibiotics and public health measures, plague is still endemic, meaning naturally present in wild rodent populations in various parts of the world, including the western United States, like in prairie dogs and squirrels. So human cases still occur sporadically, usually from flea bites in those areas. It's a reminder that these ancient threats can linger.
Definitely a sobering reminder. Okay, another fascinating tick-borne illness is relapsing fever. Caused by Borrelia species, you said?
Yes, caused by several species of Borrelia, which are spirochetes, those long spiral-shaped bacteria. Transmitted either by soft ticks or Nithodoros, or by body lice, Pediculus humanus, depending on the specific Borrelia species and geographic region.
And relapsing fever, the name seems pretty descriptive.
It is. The disease is aptly named because it's characterized by recurring episodes of high fever, chills, headache, and muscle aches, each lasting several days, followed by a period where the symptoms disappear, only to return again.
Why the relapse? Why does it keep coming back?
It's due to a remarkable mechanism of immune evasion by the Borrelia bacteria. During each fever episode, your immune system mounts a response and produces antibodies against the specific surface antigens of the spirochetes circulating at that time.
Okay, so the immune system starts clearing them.
Right. But a small number of the spirochetes manage to switch their surface antigens, essentially changing their outer coat. When these antigenically different variants multiply, the previous antibodies are no longer effective against them.
Ah, they changed their disguise.
Exactly. This new population grows, causing another relapse of fever. Your immune system then makes new antibodies against this variant, clears most of them. But again, a few switch antigens leading to another relapse, and so on. This cycle of fever and remission can repeat several times if untreated.
That's incredibly clever, biologically speaking. How is it diagnosed?
Interestingly, and somewhat unusually for spirochetes, which are often hard to see, during the fever episodes of relapsing fever, large numbers of the Borrelia spirochetes are often present in the patient's blood, so they can frequently be observed directly using a microscope to examine a blood smear stained appropriately. That's quite helpful for diagnosis.
Okay. And speaking of Borrelia and ticks, here's where we discuss Lyme disease. You mentioned it's the most common vector-borne disease in the United States.
It is, by far, caused by the spirochete Borrelia burgdorferi and in some cases other related Borrelia species, and it's transmitted by the bite of infected exotoxins ticks, often called deer ticks or black-legged ticks.
Exotoxins ticks. And understanding their life cycle is key, right?
Yeah, absolutely. The life cycle is critical to understanding its spread and risk.
Mm.
The exotoxins tick has a 2-year life cycle involving 3 feeding stages: larva, nymph, and adult.
Okay.
As a tiny larva, the tick usually takes its first blood meal from a small mammal, often a white-footed mouse. If that mouse is infected with Borrelia burgdorferi, the larva picks up the bacteria.
So the mouse is the reservoir.
Mice are a major reservoir, yes.
Mm-hmm.
The larva then molts into a nymph. The nymph takes another blood meal the following spring or summer, often again from a mouse or maybe another small mammal or bird. This nymphal stage is crucial for human infection.
Why the nymph?
Because the nymph is incredibly small, about the size of a poppy seed. It's very easy to miss on your skin. And it's actively seeking a host during late spring and summer, exactly when people are outdoors more often. So most human Lyme disease cases result from the bite of an infected nymph.
Okay, the tiny nymph is the main culprit for humans. What about the adult tick?
The adult tick usually feeds later in the fall or the following spring, typically on larger mammals, most famously white-tailed deer. Deer are important for sustaining the tick population, acting as hosts for adult ticks to feed and reproduce. But deer are generally not competent reservoirs for Borrelia burgdorferi itself. They don't really maintain the bacteria well.
So deer help the ticks, but mice help the bacteria.
That's a good way to put it.
Okay, the classic early symptom we hear about is the bullseye rash, erythema migrans.
Yes. The characteristic erythema migrans rash is a key early sign in many, but not all cases. It typically appears 3 days to a month after the tick bite, often starting as a red spot that gradually expands outwards, sometimes with central clearing, creating that bullseye appearance. It's usually not itchy or painful.
But you said not all cases. What if that rash doesn't appear, or the disease is missed early on?
That's a crucial point. The bullseye rash is diagnostic when present, but estimates vary. Maybe 20–30% of people infected don't develop or don't notice this classic rash.
So you could have Lyme without the rash.
Absolutely. And if the infection isn't diagnosed and treated promptly with appropriate antibiotics, usually doxycycline or amoxicillin, the Borrelia burgdorferi bacteria can disseminate from the initial bite site through the bloodstream to other parts of the body.
What happens then?
This can lead to later stages of the disease appearing weeks, months, or even years later. These can involve the heart, causing Lyme carditis with issues like heart block. The nervous system, leading to neurological Lyme disease with complications such as facial palsy like Bell's palsy, meningitis, radiculoneuropathy, shooting pains or numbness, and sometimes cognitive issues like memory loss or difficulty concentrating.
Wow, serious neurological effects.
Yes. And eventually, it can result in chronic Lyme arthritis, typically causing swelling and pain in one or more large joints, especially the knees. Early detection and treatment are absolutely vital to prevent these potentially debilitating long-term complications.
Definitely sounds like something to take seriously. Okay, finally in this vector-borne bacterial section, let's cover the typhus diseases. Caused by rickettsia, as you said. These are quite unique bacteria, aren't they?
They are indeed. Rickettsias are fascinating and rather unusual bacteria. They are obligate intracellular parasites.
Obligate intracellular, meaning they have to live inside other cells.
Exactly. They cannot survive or multiply outside of a host cell. They specifically target and infect the endothelial cells, which are the cells lining the walls of small blood vessels.
Okay, inside the blood vessel lining.
And they're typically spread by arthropod vectors, lice, fleas, or ticks, depending on the specific rickettsial disease. Once inside the endothelial cells, they multiply, causing damage to the blood vessels. This leads to inflammation, leakage, and sometimes blockage of the vessels, which accounts for many of the symptoms like rashes and organ damage.
So, what are the main types of typhus?
There are several important ones. First, there's epidemic typhus, caused by Rickettsia prowazekii. This is historically significant, often associated with wars, famine, and poverty situations with crowding and poor sanitation.
Why those conditions?
Because it's spread by the human body louse, Pediculus humanus humanus. Lice thrive in crowded conditions where people can't bathe or change clothes regularly. The lice transmit the bacteria through their feces, which gets scratched into the skin. Epidemic typhus causes high fever, severe headache, and a characteristic rash. Tragically, Anne Frank and her sister Margot are believed to have died from epidemic typhus in the Bergen-Belsen concentration camp.
A grim historical connection. What other types?
Then there's endemic murine typhus, sometimes just called endemic typhus or murine typhus. This is caused by Rickettsia typhi.
Murine suggests mice or rats.
Exactly. The main reservoirs are rodents, especially rats, and it's transmitted to humans by the bite of infected rat fleas. The same Xenopsilla chiapus involved in plague transmission. Endemic typhus is generally milder than epidemic typhus, but still causes fever, headache, and rash. It occurs worldwide, including in parts of the southern U.S. like Texas and California.
Okay. And then there's Rocky Mountain spotted fever.
Right. Rocky Mountain spotted fever, or RMSF, is caused by Rickettsia rickettsii. Despite its name, it's actually most common not in the Rocky Mountains, but in the southeastern and south-central United States.
Not the Rockies. That's confusing.
It is a bit confusing.
Yeah.
It was first recognized in the Rocky Mountain states, hence the name, but the highest incidence is now elsewhere. It's transmitted by the bite of infected hard ticks, like the American dog tick, Dermacentor variabilis, and the Rocky Mountain wood tick, Dermacentor andersoni.
And what are the symptoms? Is the spotted fever part accurate?
RMSF is considered the most severe rickettsial illness in the U.S. It typically starts with sudden onset of fever, headache, and muscle pain. A characteristic rash usually appears a few days later, often starting on the wrists and ankles and then spreading to the trunk. Importantly, this rash can also appear on the palms of the hands and soles of the feet, which is quite distinctive and different from many common viral rashes.
Palms and soles. That's a key sign.
It can be, yes. RMSF can progress rapidly to become a severe multi-system illness if not treated early with doxycycline. It can cause vasculitis, inflammation of blood vessels throughout the body, leading to organ damage, neurological complications, and even death. Prompt diagnosis and treatment are critical.
Definitely sounds like it. Okay, let's shift our focus now from bacteria to viruses that impact these vital cardiovascular and lymphatic systems. Where should we start? Maybe with Epstein-Barr virus?
Good place to start. Epstein-Barr virus, or EBV, which is officially known as human herpes virus 4, HHV4. It's incredibly common.
And it's linked to more than just mono, right? Like Burkitt's lymphoma.
Exactly. EBV causes Burkitt's lymphoma, which is a type of B-cell lymphoma. It's characterized by fast-growing tumors, classically involving the jaw, and is particularly common in children in certain parts of Africa.
Why Africa specifically? Is there a connection?
There seems to be a fascinating and crucial connection to malaria. It's thought that chronic malaria infection, which is hyperendemic in those regions, weakens the immune system's ability to control EBV infection.
Ah, malaria lowers the defenses against EBV.
Precisely. This impaired immune response allows the EBV-infected B cells to proliferate uncontrollably, eventually leading to the development of a lymphoma. It's a striking example of how co-infection can influence disease outcomes.
Interesting interplay, and of course most of us are far more familiar with another common EBV infection, infectious mononucleosis, or just mono, famously known as the kissing disease.
It is indeed famously transmitted through saliva, hence the nickname. While EBV infection in early childhood often causes very mild or even no symptoms, if you get infected for the first time during adolescence or young adulthood, you're much more likely to develop the classic symptoms of mono.
Which are?
Typically fever, a very sore throat, often with exudate on the tonsils, significant fatigue, and swollen lymph nodes, particularly in the neck.
And why do you feel so wiped out with mono?
A lot of the symptoms, especially the fatigue and swollen glands, are actually due to the body mounting a vigorous immune response against the infected B lymphocytes. Specifically, there's a proliferation of cytotoxic T cells trying to eliminate the infected cells. It's this intense immune battle that often makes you feel so unwell.
The immune response itself causes the symptoms.
To a large extent, yes. And one potential, though rare, complication of this intense response is spleen enlargement. In some cases, particularly during vigorous physical activity, the enlarged spleen can rupture, which is a serious medical emergency. That's why avoiding contact sports is usually recommended during recovery from mono.
Good advice. Okay, another incredibly common virus in this family is cytomegalovirus, or CMV, also a herpes virus, HHV5. You said almost all of us get infected.
Yes, CMV is extremely widespread. It's estimated that a very high percentage of the adult population worldwide, maybe 50–80% or even higher in some places, has been infected with CMV, often without ever knowing it, because primary infection in healthy individuals is usually asymptomatic or causes only a mild flu-like illness.
So if it's usually harmless, when is it a problem?
Like other herpes viruses, CMV establishes a latent infection after the primary exposure, meaning it stays dormant in your body for life, typically within certain white blood cells like monocytes. It becomes a problem mainly in situations where the immune system is weakened.
Such as?
Well, a major concern is congenital CMV infection. If a pregnant woman experiences a primary CMV infection her first exposure during pregnancy, the virus can cross the placenta and infect the fetus.
And that causes problems for the baby.
It can cause severe problems. Congenital CMV is a leading infectious cause of birth defects in the U.S., potentially resulting in hearing loss, vision impairment, microcephaly, small head size, intellectual disability, and other developmental issues.
That's serious. What about afterbirth?
CMV is also a major opportunistic pathogen in immunocompromised individuals. For example, in patients with advanced HIV/AIDS before effective antiretroviral therapy, CMV retinitis causing blindness was common. It can also cause severe pneumonia, colitis, or hepatitis in transplant recipients or others on immunosuppressive drugs.
Okay. How is it diagnosed? You mentioned something about owl's eyes.
Right. In tissue samples from infected individuals, CMV can cause infected cells to become greatly enlarged. Cytomegalo means large cell. Inside the nucleus of these enlarged cells, a characteristic large, dense inclusion body can often be seen, sometimes surrounded by a clear halo. This gives it a distinctive appearance resembling an owl's eye, which is quite helpful for pathologists making a diagnosis from biopsies.
Owl's eye inclusion bodies. Memorable. Okay, now, let's talk about some tropical viral diseases that seem to be gaining increasing global relevance, partly due to travel, partly climate change. Chikungunya, for instance. The name itself, you said, means that which bends up.
That's right. The name comes from the Makonde language of Tanzania and refers to the contorted posture of people suffering from the severe, often debilitating joint pain, arthralgia, that is a hallmark of this disease.
So severe joint pain plus what else?
Usually it starts abruptly with high fever, headache, muscle pain, and often a rash. But the joint pain is really characteristic. It can be intense, affecting multiple joints, especially smaller joints in the hands and feet, and can sometimes persist for weeks, months, or even years after the acute illness, causing chronic arthritis.
And why is this spreading so rapidly now? You mentioned mosquitoes.
Yes, it's transmitted by Aedes mosquitoes, primarily Aedes aegypti, and significantly for its recent expansion, Aedes albopictus. the Asian tiger mosquito.
The Asian tiger mosquito. Why is that one important?
Because Aedes albopictus is a particularly aggressive daytime biter, and critically, it can survive and thrive in more temperate climates compared to Aedes aegypti. There was also a mutation in the chikungunya virus itself that adapted it to replicate more efficiently within Aedes albopictus.
Ah, a virus mutation meeting a more adaptable mosquito.
Exactly. This combination allowed the virus to spread rapidly out of Africa and Asia into new regions, including Europe and the Americas, wherever the Asian tiger mosquito has established itself. And as global temperatures rise, the geographic range of this mosquito is predicted to expand further, potentially bringing diseases like chikungunya and dengue into new areas.
So vector control, controlling the mosquitoes, is absolutely crucial for these illnesses.
It is paramount, but it's incredibly challenging. The fundamental strategy is eliminating standing water, where Aedes and mosquitoes breed things like flower pots, old tires, bird baths, gutters. They can breed in tiny amounts of water.
So source reduction is key. What else?
Community efforts for source reduction are vital. Personal protection includes using insect repellents, wearing long sleeves and pants, and using screens on windows and doors. Public health measures might involve insecticide spraying, but resistance is a growing problem.
Are there more innovative approaches being tried?
Yes, there's ongoing research into several innovative approaches. Things like specially designed water storage covers, OV traps that specifically lure and trap egg-laying female mosquitoes, and various biological controls.
Biological controls, like what?
Like introducing larvae-eating copepods, tiny crustaceans, or certain fish, like mosquito fish, into water containers where feasible. Or using mosquito dunks, which contain spores of the bacterium, the Bacillus thuringiensis israelensis,
Right.
BT. BT produces toxins that specifically kill mosquito larvae, but are harmless to other organisms.
BT, okay.
There's even fascinating, though sometimes controversial, research into releasing genetically modified male mosquitoes that are sterile or carry genes that kill their offspring. The idea is to drastically reduce the wild mosquito population over time.
Wow, genetic approaches too. Okay, then there are the classic viral hemorrhagic fevers, like yellow fever, also mosquito-borne.
Yes, yellow fever is another disease transmitted by Aedes aegypti mosquitoes, primarily in tropical regions of Africa and South America. It's caused by a flavivirus.
And it gets its name from?
From the jaundice, the yellowing of the skin and eyes that occurs in the severe phase of the illness due to liver damage. The disease typically starts with fever, chills, headache, back pain, nausea, and vomiting. Most people recover, but about 15% enter a more toxic phase with jaundice, abdominal pain, bleeding, hemorrhage from the mouth, nose, eyes, or stomach, and kidney failure. This phase has a high mortality rate, maybe 20–50%.
Is there a vaccine?
Yes. Thankfully, there is a very effective live attenuated vaccine for yellow fever that provides long-lasting immunity. Vaccination is recommended, sometimes required, for travel to endemic areas. Historically, Walter Reed's groundbreaking work in Cuba proved that mosquitoes transmitted yellow fever, leading to successful mosquito control campaigns that helped eradicate it from places like the U.S.
A public health success story. Now, dengue fever is often mentioned alongside yellow fever, also a flavivirus.
Yes, dengue is caused by another flavivirus, also transmitted primarily by Aedes aegypti and Aedes albopictus mosquitoes. It's actually one of the most rapidly spreading mosquito-borne diseases globally, with huge epidemics occurring in tropical and subtropical regions.
How does it compare to yellow fever? Is it usually milder?
Classic dengue fever is often similar initially: high fever, severe headache, especially behind the eyes, muscle and joint pain, giving it the nickname breakbone fever, nausea, vomiting, and sometimes a rash. It's typically debilitating, but usually not fatal.
Usually not fatal. But there's severe dengue.
Yes. A small percentage of dengue infections progress to severe dengue, previously known as dengue hemorrhagic fever, DHS, or dengue shock syndrome, DSS. This is characterized by plasma leakage from blood vessels, fluid accumulation, respiratory distress, severe bleeding, and potentially organ impairment. Severe dengue is a medical emergency and can be a leading cause of death, especially among children in endemic countries.
Why does severe dengue happen? Is it random?
It's not entirely random. One major risk factor is having a previous infection with a different serotype of the dengue virus. There are 4 main dengue virus serotypes: DNV1, NAGA2, NAGA3, 4.
4 types.
Yes. Infection with one serotype provides lifelong immunity to that specific serotype, but only temporary partial immunity to the others. What's particularly concerning is a phenomenon called antibody-dependent enhancement, or ADE.
Antibody-dependent enhancement sounds bad.
It is. It's thought that pre-existing antibodies from a previous infection with one dengue serotype, when a person is later infected with a different serotype, might not neutralize the new virus effectively. Instead, these non-neutralizing antibodies might actually bind to the new virus and help it enter certain immune cells, like macrophages, more efficiently.
So the old antibodies actually help the new virus.
Paradoxically, yes, that's the hypothesis. This enhanced viral replication within immune cells could lead to a more intense immune response, increased vascular permeability, and a higher risk of developing severe dengue. This makes developing a safe and effective dengue vaccine very challenging, as you need to protect against all four serotypes simultaneously without potentially increasing the risk of ADE.
A very tricky immunological problem. Okay, beyond yellow fever and dengue, there are other, perhaps even scarier, emerging viral hemorrhagic fevers, like Marburg and Ebola.
Yes, Marburg and Ebola viruses belong to the filovirus family. They cause severe, often fatal hemorrhagic fevers characterized by sudden onset of fever, intense weakness, muscle pain, headache, sore throat, followed by vomiting, diarrhea, rash, impaired kidney and liver function, and in many cases, profuse internal and external bleeding.
Where do they come from?
They are zoonotic, meaning they originate in animals and occasionally spill over into human populations. The natural reservoir hosts are thought to be certain species of fruit bats. Humans typically get infected through close contact with infected animals like bats or primates, or through contact with the bodily fluids of infected humans.
And the mortality rates are extremely high, right?
Historically, yes, case fatality rates for Ebola and Marburg outbreaks have ranged from 25% to as high as 90%, depending on the specific virus strain and the availability of supportive care. They cause devastating outbreaks, particularly in parts of Africa.
Is there any good news regarding Ebola? Maybe treatments or vaccines?
There has been significant progress, thankfully. While specific antiviral treatments are still limited, advances in supportive care have improved survival rates. More importantly, a highly effective recombinant vaccine called RVSV-ZBOBOFI has been developed and licensed.
Our vaccine, how is it used?
It has been crucial in controlling recent Ebola outbreaks using a ring vaccination strategy. When a case is confirmed, health workers vaccinate all the contacts of that person and the contacts of those contacts, creating a protective ring of immunity to stop the virus from spreading further. It's been a game changer.
That's fantastic news. Are there other emerging hemorrhagic fevers we should know about?
Yes, unfortunately. There's Lassa fever, caused by an arenavirus, endemic in parts of West Africa, with rodents as the reservoir. There are various South American hemorrhagic fevers, also caused by arenaviruses carried by rodents. And then there's hantavirus.
Hantavirus, I've heard of that one. Also from rodents.
Yes, hantaviruses are carried by various species of rodents worldwide. Humans typically become infected not through bites, but by inhaling aerosols of dried rodent urine, feces, or saliva, often when cleaning out barns, sheds, or cabins where infected rodents have been present.
Inhaling it. Wow, what does it cause?
Different hantaviruses cause different syndromes. In the Americas, certain strains cause hantavirus pulmonary syndrome, HPS, a severe respiratory illness that starts with flu-like symptoms but rapidly progresses to respiratory failure as fluid fills the lungs. HPS has a high fatality rate, around 30–40%. In Europe and Asia, other hantavirus strains cause hemorrhagic fever with renal syndrome, HFRS, which involves fever, bleeding, and acute kidney injury.
Scary stuff originating from common animals like rodents.
Okay, let's shift gears again. Our internal highways aren't just vulnerable to bacteria and viruses. Single-celled protozoa and even larger parasitic worms, helminths, can also cause serious systemic diseases. Where should we start here? Maybe Chagas disease.
Chagas disease is a very important one, yes. Also known as American trypanosomiasis.
Oh.
It's caused by a flagellated protozoan parasite called Trypanosoma cruzi.
American trypanosomiasis, so primarily in the Americas.
Yes, it's endemic throughout much of Central and South America, where it chronically infects millions of people. It's considered a major neglected tropical disease.
How is it transmitted? Is there a vector? There is. The vector is a type of insect commonly known as the kissing bug, or reduvid bug. These bugs often live in the cracks and crevices of poorly constructed houses, especially those made of mud, adobe, or thatch.
Kissing bug. Why that name?
Because they tend to bite humans, often at night, typically on the face, near the lips or eyes, while the person is sleeping. But the transmission isn't directly through the bite itself.
Oh, how then?
While the kissing bug is taking its blood meal, it often defecates on the person's skin. The bug's feces contain the Trypanosoma cruzi parasites. The bite site is often itchy, so the person then instinctively scratches or rubs the area, accidentally introducing the infected feces into the bite wound or into mucous membranes like the eyes or mouth.
Ugh, so you rub the parasite into yourself.
Essentially, yes.
Yeah.
That's the primary mode of transmission. It can also be transmitted congenitally from mother to baby through blood transfusions or organ transplants from infected donors, and occasionally through contaminated food or drink.
So what does this mean for someone who gets infected? What does the disease look like?
Chagas disease has two main phases, an acute phase and a chronic phase. The acute phase occurs shortly after infection and might be mild or even asymptomatic, maybe causing fever, malaise, swelling at the bite site, called a chagoma, or eyelid swelling if that's where the parasite entered, the Romingus sign. Often, it goes unnoticed.
So the initial infection might be missed. What about the chronic phase?
That's where the real danger lies. After the acute phase, the infection enters a chronic, indeterminate phase where the person has no symptoms, but the parasites are still present in their body. This can last for decades. However, in about 20–30% of infected individuals, the disease eventually progresses to the chronic determinate phase, years or even decades after the initial infection.
And what happens then?
This is where severe, irreversible damage can occur, primarily to the heart and the digestive system. Chronic Chagas cardiomyopathy involves inflammation and fibrosis of the heart muscle, leading to arrhythmias, heart failure, and potentially sudden death. Chronic digestive complications involve enlargement of the esophagus, megaesophagus, or colon, megacolon, causing difficulties with swallowing or constipation. These chronic complications are often fatal.
That sounds incredibly serious, especially developing years later. You mentioned it's difficult to treat. Why is that?
It's notoriously difficult to treat, especially in the chronic phase. The available antiparasitic drugs, benznidazole and nifurtimox, are more effective if given during the acute phase, but they often have significant side effects and are much less effective at eliminating the parasites once the chronic stage is established. A major reason for the difficulty is that the Trypanosoma cruzi parasite multiplies inside host cells, particularly muscle cells, including heart muscle and nerve cells.
Hiding inside cells again.
Exactly. This intracellular location makes it very hard for drugs circulating in the bloodstream to reach and eliminate all the parasites effectively.
Yeah.
So preventing transmission through vector control and screening blood donors is crucial.
Makes sense. Okay, next up, let's talk about toxoplasmosis, caused by Toxoplasma gondii. This one has a surprising connection, doesn't it, to cats?
It absolutely does. Toxoplasma gondii is another protozoan parasite, and domestic cats, along with other felines, are the definitive hosts. This means cats are an essential part of its complex life cycle, and they are the only hosts that shed the environmentally resistant form of the parasite called oocysts in their feces.
So cats spread it through their feces?
Yes. An infected cat can shed millions of these microscopic oocysts in its feces for a couple of weeks. These oocysts then mature in the environment, soil, litter boxes, over several days and become infectious.
How do humans usually get infected? From cats directly?
Actually, direct contact with cat feces is a less common route for human infection than many people think, although cleaning litter boxes does pose a risk if proper hygiene isn't followed. The most common way humans get infected globally is by eating undercooked or raw meat, particularly pork, lamb, or venison, that contains dormant tissue cysts of the parasite.
Undercooked meat. Okay. Any other ways?
Yes. You can also get infected by ingesting food or water contaminated with oocysts shed by cats, like unwashed vegetables from a garden where cats defecate, or accidentally ingesting oocyst after gardening or handling contaminated soil without washing hands. And, like Chagas, it can be transmitted congenitally or through organ transplantation.
So most people who get toxoplasmosis, do they even know it?
Usually not. In healthy individuals with a normal immune system, toxoplasma infection is typically asymptomatic or causes only mild, flu-like symptoms like swollen lymph nodes or muscle aches. The immune system generally keeps the parasite in check, forming dormant tissue cysts, bradyzotes, that can persist for life, usually without causing problems. It's estimated that a significant portion of the global population, maybe over 22% in the U.S., has been infected and carries these dormant cysts without even realizing it.
So over a fifth of people might have it and not know, but there's a serious concern, especially for pregnant women, right?
Yes, that's where the risk becomes significant and why pregnant women are often advised to take precautions. If a woman acquires her primary, first-time toxoplasma infection during pregnancy, the parasite can cross the placenta and infect the developing fetus.
And that causes problems.
It can cause severe problems for the baby, known as congenital toxoplasmosis. The consequences can include miscarriage, stillbirth, or serious long-term issues for the child, such as eye infections leading to vision loss, ocular toxoplasmosis, hearing loss, hydrocephalus, water on the brain, seizures, and intellectual disability. The risk and severity depend on when during the pregnancy the infection occurs.
That's why pregnant women are told to avoid raw meat and maybe avoid cleaning the litter box.
Exactly. Avoiding raw or undercooked meat, thoroughly washing fruits and vegetables, washing hands after gardening, and having someone else change the cat litter box daily, as oocysts take a few days to become infectious, are key preventive measures during pregnancy.
Okay. And what about immunocompromised people?
That's the other major risk group. In individuals with severely weakened immune systems, particularly those with advanced HIV/AIDS or undergoing certain cancer treatments or organ transplant recipients, the dormant toxoplasma cysts can reactivate.
Reactivate.
Yes. The parasites start multiplying again and can cause severe life-threatening disease, most commonly toxoplasmic encephalitis, which is inflammation of the brain. This can lead to seizures, neurological deficits, coma, and death if not treated promptly. So toxoplasmosis is a major opportunistic infection in these populations.
Right. Okay, moving to perhaps the most globally impactful protozoan disease, malaria. We associate it with recurring cycles of chills, fever, vomiting, and headaches.
Malaria is indeed a global health catastrophe. It's caused by protozoan parasites of the genus Plasmodium. 4 main species infect humans: Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, and Plasmodium malaria. A 5th, Plasmodium knowlesi, normally infects macaques but can also infect humans.
And it's transmitted by mosquitoes.
Yes, specifically by the bite of infected female Anopheles mosquitoes. Only female mosquitoes bite, as they need blood meals for egg development.
Anopheles mosquitoes, different from the Aedes that spread dengue and chikungunya.
Correct. Different genus, different behaviors often too. Anopheles mosquitoes are typically night feeders, biting between dusk and dawn, which is why insecticide-treated bed nets are such an important preventive tool.
Okay. The life cycle of Plasmodium is notoriously complex, isn't it?
It is incredibly complex, involving stages in both the mosquito vector and the human host. Let's break down the human part.
Please.
When an infected Anopheles mosquito bites you, it injects Plasmodium sporozoites from its salivary glands into your bloodstream. These sporozoites quickly travel to your liver.
First stop, the liver.
Yes, inside liver cells, the sporozoites multiply asexually over about a week or two, producing thousands of merozoites per sporozoid. This liver stage is clinically silent. You don't feel sick yet. For P. vivax and P. ovale, some parasites can remain dormant in the liver as hypnozoites, capable of causing relapses weeks or months later.
Hypnozoites, sleeping forms. Okay, what happens after the liver stage?
The liver cells eventually rupture, releasing the merozoites into the bloodstream. These merozoites then invade your red blood cells, erythrocytes.
Now they're in the blood cells.
Right. Inside the red blood cells, the merozoites mature and multiply asexually again, going through stages called ring, trophozoite, and schizont. Eventually, the infected red blood cell ruptures, releasing many new merozoites, which then quickly invade other red blood cells, repeating the cycle.
And this is when you feel sick.
Yes. It's the cyclical rupture of infected red blood cells and the release of merozoites, parasite waste products, and cellular debris into the bloodstream that triggers the characteristic symptoms of malaria. The sudden onset of shaking chills, followed by high fever and then profuse sweating. These paroxysms typically occur every 48 hours, P. falciparum, P. vivax, P. ovale, or 72 hours, P. malaria, corresponding to the parasite's reproductive cycle in the blood.
So the fever cycle matches the parasite cycle.
Exactly. Other symptoms include headache, muscle aches, fatigue, nausea, vomiting, and anemia due to the destruction of red blood cells.
You mentioned the global impact is staggering.
It's devastating. Malaria affects hundreds of millions of people worldwide each year, primarily in sub-Saharan Africa and parts of Asia and Latin America. It causes hundreds of thousands of deaths annually, disproportionately affecting young children under 5 and pregnant women in endemic regions.
Which species is the most dangerous?
Plasmodium falciparum causes the most severe and life-threatening form of malaria, often called malignant malaria.
Why is falciparum so dangerous?
For several reasons. It can infect red blood cells of all ages, leading to very high levels of parasites in the blood, parasitemia. Also, red blood cells infected with P. falciparum develop knobs on their surface that cause them to stick to the walls of small blood vessels, cytoadherence.
Stick to the blood vessels.
Yes, particularly in vital organs like the brain, lungs, kidneys, and placenta. This sequestration of infected red blood cells obstructs blood flow, leading to oxygen deprivation and tissue damage. In the brain, this causes cerebral malaria, characterized by seizures, coma, and often death. Falciparum malaria can also cause severe anemia, respiratory distress, kidney failure, and other life-threatening complications.
That sounds incredibly dangerous. So, why is developing a malaria vaccine proving so incredibly difficult?
It's one of the holy grails of vaccinology, but it's immensely challenging for several reasons. First, the Plasmodium parasite has a very complex life cycle with different stages: sporozoite, liver stage, blood stage, gametocyte, expressing different antigens, so an effective vaccine might need to target multiple stages.
A multi-stage target.
Right. Second, the parasite is genetically complex, possessing thousands of genes, many more than viruses or bacteria. This genetic diversity allows it to readily mutate and change its surface antigens, effectively evading the host immune system. It's a master of disguise.
Constantly changing its code again.
Pretty much. Third, developing sterilizing immunity, the kind that completely prevents infection, is very difficult to achieve naturally, even after repeated infections, let alone with a vaccine. While progress is being made with one vaccine, RTS muscarix, now being deployed in parts of Africa showing partial efficacy, we still don't have a highly effective, long-lasting malaria vaccine. That's why prevention through mosquito control, like bed nets and insecticides, and prompt diagnosis and treatment with anti-malarial drugs remain the cornerstones of malaria control.
A huge ongoing challenge. Okay, another widespread protozoan disease is leishmaniasis, caused by Leishmania species and transmitted by sandflies.
Correct. Leishmaniasis is caused by various species of the protozoan parasite Leishmania, and it's transmitted by the bite of infected female phlebotomine sandflies. These are tiny flies, much smaller than mosquitoes, often found in tropical and subtropical regions, but also in some temperate areas.
And does it cause just one type of disease?
No, leishmaniasis actually manifests in several distinct clinical forms, depending on the specific Leishmania species involved and the host's immune response. The three main forms are visceral, cutaneous, and mucocutaneous leishmaniasis.
Visceral leishmaniasis involving the organs.
Yes. Visceral leishmaniasis, also known as Kala-Azar, is the most severe form and is fatal if left untreated. The parasites infect macrophages throughout the reticuloendothelial system, particularly in the spleen, liver, and bone marrow. This leads to prolonged fever, weight loss, massive enlargement of the spleen and liver, hepatosplenomegaly, anemia, and susceptibility to other infections.
Sounds very serious. What about cutaneous leishmaniasis?
Cutaneous leishmaniasis is the most common form. It causes skin sores or ulcers at the site of the sandfly bite. These sores can range from small papules to large chronic ulcers. They typically heal slowly over months or years, but often leave behind significant disfiguring scars.
Disfiguring scars. And mucocutaneous.
Mucocutaneous leishmaniasis is less common, but particularly destructive. It starts as a skin ulcer, but then the parasites spread to the mucous membranes of the nose, mouth, and throat. This leads to progressive, disfiguring destruction of these tissues, sometimes years after the initial skin lesion healed. It can cause severe facial disfecement and difficulty breathing or swallowing.
That sounds horrific. Is leishmaniasis also an opportunistic infection?
Yes, it's an important opportunistic infection, particularly visceral leishmaniasis, in individuals with weakened immune systems, such as those co-infected with HIV. Leishmania HIV co-infection is a growing problem in some regions and makes treatment much more difficult.
Okay. Finally, in this protozoan category, let's briefly touch on babesiosis, another tick-borne disease.
Yes, babesiosis is caused by protozoan parasites of the genus Babesia, most commonly Babesia microti in the United States. It's transmitted by the same Ixodes ticks that transmit Lyme disease, so co-infection with both pathogens is possible.
Babesia microti. And how does it compare to malaria? You said it resembles it.
It does resemble malaria in that the Babesia parasites infect and replicate within red blood cells, causing their destruction, hemolysis. This leads to symptoms like fever, chills, sweats, headache, body aches, fatigue, and hemolytic anemia.
So similar symptoms. Is it as severe?
For most healthy people, Babesia microti infection might be asymptomatic or cause only a mild to moderate illness that resolves on its own. However, it can be much more severe, even fatal, in certain high-risk groups.
Who's at high risk?
Particularly individuals who are elderly, those who've had their spleen removed, the splenic patients, or those who are immunocompromised due to conditions like HIV, cancer, or immunosuppressive medications. In these patients, babesiosis can cause life-threatening complications like severe anemia, respiratory distress, disseminated intravascular coagulation, DIC, organ failure, and shock. It's also a concern for transmission through blood transfusions.
So, dangerous for vulnerable groups. Okay, it's not just single-celled microbes. Even larger parasitic worms, helminths, can take up residence in our circulatory system. Let's look at schistosomiasis, caused by blood flukes of the genus Schistosoma.
Schistosomiasis, also known as bilharzia, is a major parasitic disease caused by trematodes, or flukes, specifically species of schistosoma. These worms live within the blood vessels of infected humans.
Blood flukes, living in blood vessels.
Yes, the adult worms reside in specific veins depending on the species. For example, Schistosoma mansoni and Schistosoma japonicum typically live in the mesenteric veins draining the intestines, while Schistosoma hematobium lives in the veins around the bladder.
And you said it's incredibly widespread.
It is. Schistosomiasis is a truly debilitating disease, second only to malaria in terms of the number of people affected globally by a parasitic disease, impacting hundreds of millions, primarily in tropical and subtropical areas of Africa, Asia, and South America, where specific freshwater snails exist.
Snails, what do they have to do with it?
Freshwater snails are essential intermediate hosts in the schistosomal life cycle. The cycle is complex. Infected humans excrete parasite eggs in their feces, or urine, into freshwater sources.
Okay.
If these eggs reach water, they hatch, releasing larvae called muricidia. These muricidia must find and penetrate a suitable species of freshwater snail within hours. Inside the snail, the parasite undergoes further development and asexual multiplication over several weeks.
Multiplies inside the snail.
Yes, producing thousands of free-swimming larvae called cercaria. These cercariae are then released from the snail back into the water.
And this is how humans get infected, from the water.
Exactly. Humans become infected when their skin comes into contact with water contaminated with these cercariae, perhaps while swimming, bathing, washing clothes, or working in agriculture. These cercariae actively penetrate intact human skin.
They burrow through the skin.
Yes. Once inside the body, they transform, migrate through the tissues and lungs, and eventually mature into adult male and female worms in the liver portal system. The adult worms then pair up and migrate to their final residence in the mesenteric or bladder veins.
Adult worms living in our veins. How long do they live?
Remarkably, adult schistosomes can live for years, sometimes even decades, within the human host, continuously producing eggs.
Decades? How do they survive the immune system for so long?
They have evolved incredibly clever mechanisms to evade the host immune response. One key strategy is that the adult worms coat themselves with host proteins, essentially camouflaging themselves. They acquire a layer of host molecules on their outer surface, tegument, that makes them look like self to the immune system.
Molecular mimicry again, but with whole worms.
Sort of, yes. This molecular disguise allows them to remain largely invisible and unaffected by the host's immune attack.
So if the worms themselves are hidden, what causes the disease? You mentioned eggs earlier.
Precisely. The major pathology, the actual disease symptoms of schistosomiasis, are not caused by the adult worms themselves, but by the body's reaction to the vast numbers of eggs they produce. Female worms release hundreds or thousands of eggs per day.
Thousands of eggs a day. Where do they go?
Some eggs are excreted in the feces or urine, perpetuating the life cycle. But many eggs become trapped in the tissues of the host, particularly the liver and intestines for S. mansoni and S. japonicum, or the bladder and ureters for S. hematobium.
Trapped eggs. What does the body do?
The trapped eggs elicit a vigorous inflammatory and immune response from the host. The body tries to wall off these foreign objects by forming granulomas around them. These are nodules of inflammatory cells.
Granulomas, like scar tissue.
Over time, yes, chronic granuloma formation leads to fibrosis or scarring in the affected organs. In intestinal schistosomiasis, this can cause liver fibrosis, portal hypertension, high blood pressure in the veins supplying the liver, enlargement of the spleen, and accumulation of fluid in the abdomen, ascites. In urinary schistosomiasis, it can cause bladder inflammation, blood in the urine, hematuria, bladder cancer, and kidney damage. This chronic inflammation and organ damage is what causes the severe morbidity associated with schistosomiasis.
A disease caused by the reaction to the eggs, not the worms themselves. Fascinatingly tragic. How is it prevented?
Prevention and control rely on several strategies. Improving sanitation and access to clean water is crucial to prevent human waste containing eggs from contaminating freshwater sources. Controlling the specific snail populations that act as intermediate hosts is another approach, often using melicicides, snail-killing chemicals, although this can have environmental impacts. Mass drug administration with the drug praziquantel is used to treat infected populations and reduce transmission, and health education about avoiding contact with contaminated water is also important.
A multi-pronged approach needed. Okay, we've covered a wide array of known microbial invaders, bacteria, viruses, protozoa, helminths, but sometimes a serious illness remains a frustrating mystery. One such example you mentioned is Kawasaki syndrome.
Yes, Kawasaki syndrome, also known sometimes as Kawasaki disease. It's significant because it's now the most common cause of acquired heart disease in children in developed countries like the United States, having surpassed rheumatic fever.
More common than rheumatic fever now. Wow, what is it exactly?
It's an acute febrile illness, meaning it involves fever that primarily affects young children, typically under the age of 5. It's characterized by a constellation of symptoms.
Like what?
Usually a high fever lasting at least 5 days, often unresponsive to usual fever medications, plus several other characteristic signs. A widespread skin rash, redness and swelling of the hands and feet, sometimes with peeling later, bilateral conjunctivitis, red eyes without pus, changes in the lips and mouth like red, cracked lips, strawberry tongue, and swollen lymph nodes in the neck, cervical lymphadenopathy.
A whole collection of symptoms, but the main concern is the heart.
Yes, the most serious complication of Kawasaki syndrome is inflammation of the coronary arteries, the blood vessels that supply the heart muscle itself. This is called coronary arteritis.
Inflammation of the heart's own arteries.
Exactly. This inflammation can lead to weakening and bulging of the artery walls, forming coronary artery aneurysms. These aneurysms can potentially lead to blood clots, heart attack, myocardial infarction, or sudden death, sometimes years later. That's why early diagnosis and treatment aimed at reducing this inflammation are so critical.
And what is the treatment?
The standard treatment is high-dose intravenous immunoglobulin, IVI'd, along with aspirin, given within the first 10 days of illness. This significantly reduces the risk of developing coronary artery aneurysms.
Okay, IVIG and aspirin. But you said the cause is a mystery?
That's the puzzling aspect. Despite being relatively common and having serious potential complications, the exact cause of Kawasaki syndrome remains unknown.
Really? No idea at all.
Well, there are strong suspicions, but no definitive proof. Its clinical features, the fever, rash, lymph node involvement, and its tendency to occur in outbreaks, suggest an infectious trigger, perhaps a common virus or bacterium. However, no specific pathogen has been consistently identified despite extensive research.
So it looks infectious, but the agent is unknown.
Exactly. Another theory is that it might be an abnormal immune response, perhaps triggered by one or more common infectious agents in genetically susceptible children. There seems to be some genetic predisposition, as it's more common in children of Asian descent, particularly Japanese. But fundamentally, the trigger remains elusive.
That's truly perplexing for such a common and potentially serious condition in kids. What makes it so difficult to pinpoint the cause, and what are the implications of that ongoing mystery?
It's incredibly challenging because, unlike diseases where you can clearly isolate a specific bacterium or virus, Kawasaki doesn't present that way. If it is an infection, the trigger might be very common, maybe causing only mild illness in most people, but triggering this abnormal inflammatory response in susceptible kids. Or it might be transient, cleared by the time symptoms develop, making it hard to detect. Or maybe it's not a single agent, but a response pattern triggered by several different common infections.
So many possibilities.
Right. And the implications of not knowing the cause are profound. Without a known target pathogen, we can't develop a specific vaccine to prevent it. We can't use targeted antiviral or antibiotic therapy. Instead, as we discussed, treatment focuses on broadly dampening the excessive inflammation with IVIG and aspirin to prevent the cardiac damage. It really serves as a reminder that even with all our sophisticated diagnostic tools and scientific advances, some fundamental medical mysteries still persist, especially involving complex immune responses.
A humbling reminder indeed. And there you have it, a really deep dive into the microbial diseases that impact your cardiovascular and lymphatic systems. We've navigated everything from those microscopic pathogens hijacking your heart to ancient plagues like the Black Death and the complexities of emerging viral threats like Ebola and chikungunya.
You've now seen firsthand, hopefully, how understanding this intricate dance, this back and forth between our body's own defense mechanisms and the microbial world isn't just, academic textbook stuff. It's profoundly important for clinical relevance, for understanding what doctors deal with, for environmental awareness, and for truly grasping global health challenges.
Indeed. It genuinely underscores how interconnected everything is: our bodies, the environment, animal health, global travel, and how knowledge about these tiny, often invisible forces can have immense real-world implications, whether you're trying to make sense of a news report about an outbreak or simply considering your own health and preventative measures.
And as we look to the future, this whole discussion really leaves us with a compelling, maybe slightly unsettling question. What new microbial challenges might emerge as our global climate continues to shift, as human populations expand, as we interact more with wildlife in new environments?
That's a big question.
It is. The constant emergence and reemergence of infectious diseases, driven by factors like climate change, deforestation, globalization, antibiotic resistance, ensures that this deep dive into microbiology, into understanding these threats, is a journey that really never truly ends. There's always more to learn, always new challenges appearing.
It certainly is a dynamic field. We hope this deep dive has given you, our listeners, a newfound appreciation for your body's truly amazing internal systems, these highways and surveillance networks, and also for the vast and complex microbial world that constantly interacts with them, for better or for worse.
Yeah, it's a fascinating world inside us and around us.
Thank you so much for joining us on this exploration today. We really encourage you to keep asking questions, keep digging for knowledge, and just keep learning. There's always more to discover.